Hi, my name is David Scher. I'm back once again to talk to you about Physics 578, Medical Health Physics. We've been talking about nuclear medicine. Last time we talked about dose assessment in nuclear medicine and some dose assessment for pregnant patients. And today we're going to go back and talk a little bit about dose assessment in diagnostic radiology. So you can see the topic, just as I said. And following this, I hope to get into, it's about time for another test. And then after that, we'll get into shielding evaluations for medical applications, tasks that often falls to health physicists. So let me begin this topic. One of the problems with diagnostic imaging is similar to what we have with nuclear medicine. So in nuclear medicine, we have the isotopes being taken up by different organs and either irradiating those organs themselves or radiating other nearby organs. And that gave rise to a non-uniform pattern of exposure. That's true also in diagnostic radiology, and that's one of the complications. We can't just say that the person just got a dose. And there are reasons why the exposure is non-uniform. First of all, when we take an X-ray or develop an image with X-rays, we're not exposing the whole body. We're intentionally limiting the some region of interest, and so the whole body isn't going to be exposed. Only the structures that are in or very close to the primary beam will receive any significant radiation. Another reason that the exposures are non-uniform is we're dealing with a beam that is diverging from a point in the X-ray machine, and so from the focal spot is diverging, and so structures that are closer to the focal point will have a higher dose than structures that are further away, just based on the inverse square law. And so if we have a 1 meter distance between the focal spot, the radiation source, and the image detector, then some structures may be 30, 40 centimeters above the image receptor. And so that's a big fraction of the overall distance. And so it can lead to non-uniform exposures as well. And the other thing is that diagnostic X-ray machines emit low energy photons. We're not talking about MEV beams. These are keV range, maybe up to 100, 120 keV as the maximum energy. And so these photons are readily attenuated by tissue. And so as you go deeper into the body of the person being imaged, you're going to have a lower dose. So the exposures are non-uniform because of attenuation within the person. You can easily take an ionization chamber and measure the entrance skin exposure, but the dose at depth will be different because of both inverse square law and attenuation. And so those are some of the factors that affect exposure and why it's not just as simple as just measuring whatever is happening at the surface. So because we have this spectrum of energies emitted by an X-ray tube, and we have a variety of energies in the beam, we're going to have some variation with depth, as I said, but it's very difficult to deal with the attenuation coefficients we know about and the photon energies that we know about because it's a complex spectrum. So instead we deal with holistic parameters that describe the whole beam and something that's called beam quality. It's used as a surrogate for the spectrum, the average energy, or the beam quality is measured in terms of the half value layer. How much it's parameterized in lead, how much that material is necessary to reduce the beam in half. We talked about that before. And so that's going to be one of the parameters that's going to be important for us when we try to do dose assessment for patients. And here's a graph showing what the attenuation, the first HVL is, and how it changes as we add more material at different accelerating potentials. For 100 kVp, that is the peak accelerating potential for that sine wave is 100 kilovolts. As we add more filtration, as we add more aluminum, 2 millimeters or 2.5 millimeters of beam, then to cut it in half from that point on takes more energy than it did to begin with. So with no added attenuation for 100 kV peak beam, it looks like the HVL is 4.5 millimeters of aluminum. But we've already put in 2 millimeters of aluminum. Now it's closer to 5.8 millimeters of aluminum to cut it in half from that point. So the beam gets harder and harder, HVL gets higher and higher. And so this is just showing you that it's a complex problem, but it's parameterized by HVL. We can measure the HVL on the table and use that as our means to calculate the patient's dose. Now, this is a complicated problem. As I said, we got all kinds of radiation phenomena going on. It's a difficult radiation transport problem, just like it was for nuclear medicine, where we had all these photons starting in a source organ, go into a target organ, what kind of attenuation is taking place. So we use the same kind of computational phantoms, the anatomy, and through it, the attenuation. This is the same slide we saw for nuclear medicine, and it's the same again. Originally, the phantoms were quite stylized. They've become more realistic over time. There's been more interest in internal dosimetry in terms of these computations. I don't know that there have been a lot of new computations of radiography using the more complicated phantoms. But if any of you know more recent, I'm going to show you some dose coefficients for calculating patient dose. If any of you know of more recent dose coefficients that have been compiled, please let me know. I'll pass them along, and it'll benefit me and all of you as well. Okay, but what we're doing is we're taking this complicated problem with the complicated energy spectrum and all the different issues that lead to non-uniform exposures, and we're going to calculate that using our phantom. Only in this case, instead of one organ irradiating the other, the radiation is coming from the outside, passing through the patient, being attenuated, and depositing energy. And there are many different projections that are used. AP from the front to the back, PA from the back to the front, left or right lateral, side to side, and rotation or rotating for when we calculate CT scans, etc. So the radiation transport model is built up using this kind of geometry, evaluating photons passing through. It's a Monte Carlo type calculation, just like it was for internal dosimetry. It's very similar to the kind of calculations that are done. The parameters that are used in this evaluation are the beam energy, the beam spectrum. We'll need to know something about the mass. That will affect the dose. It doesn't affect this model. We just calculate what happens for a particular radiation per unit energy, that's per unit dose that's incident on a person. But all these different factors will affect the dose. When we're calculating what the way radiation is attenuated and absorbed in the body, for the same external beam, we calculate the HVL, and then we use the HVL as a parameter in our charts that we're going to use to estimate dose from the patient. So you'll see that, I think, in the next slide. In the next slide after this. The results of these calculations, you'll see in a moment, where they calculate all the radiation deposition through the person based on the external exposure. They're tabulated into books, and I am putting into the Blackboard site references that are available from the FDA online, freely available to everybody. And they're going to be dose coefficients, just like there were for nuclear medicine, only instead of dose per activity administered, these are going to be dose per entrance entrance exposure. How many rads entering the body, or Roentgens at the entrance of the surface, and then how many rads result as a consequence of that. They have tables for pediatrics. They have tables for mammography, tables for doses for adult radiography, and fluoroscopy, both gastrointestinal fluoroscopy and the cine fluoroscopy, the heart studies. I showed you a video of a heart catheterization, a coronary artery study early on in this course, just to get a sense of the kind of work that's done. Here's an example of the final end product, what the tables look like that we use for calculating doses. And let's go through what this is. This tells us for a beam of a given HVL, so 2.5 millimeters of lead is the half A layer. This is for a particular study. This is AP, front to back, pelvis study, or a lumbopelvic study. The source to image receptor distance, the SID, is 40 inches, and the field size is shown here, 17 inches by 14 inches. All of those parameters affect the exposure. So this is a common study, and they're giving you the parameters for this study. And what this table shows you is we've got some HVL that is measured when we operate at our normal operating techniques for this study. At 80 kVp, the half A layer is whatever. So let's say our half A layer is 2.5 millimeters of lead. Then for each rad that exposes, Roentgen of entrance skin exposure, free in air, we get 1.0 millirads of exposure to the lungs. We get 38 millirads of dose to the active bone marrow, 0.1 millirads to the thyroid, 150 millirads to the trunk tissue. And I'm going to describe what this CDI is later on. I'll just tell you now, CDI is Cancer Detriment Index. So these tables tell us what the doses are, or what the CDI is, for a 1 Roentgen exposure at the skin level, what the dose in millirads would be. It's all labeled up here on the top. This is for male, this is for female. So if this study were for a female, we'd have very similar results. In addition, we have a dose for uterus and for the ovaries also, and different cancer coefficients. Okay, as I said, the Cancer Detriment Index, the CDI, is they're using this instead of using the dose for an index as a measure of stochastic risk. When we have the effective dose, we have tissue weighting factors. We add up the doses to each of the tissues times the tissue weighting factor and get an effective dose. In the case of this CDI parameter, what we're doing is we're taking the risk of fatal cancer, R, parenthesis F, for different tissues, I of the different tissues, and then we have a risk of curable cancer, that's the R sub I, C, curable cancer risk, times the severity, what all morbidity occurs as a consequence. And all these are on a per dose basis. These are the values that they've used in this calculation. And add those all up, and that gives us what the cancer detriment risk is. Okay. The important point is that many patients want to know, are concerned about cancer when they're a child or when they are being exposed. And this gives us some index, some indicator of the kind of risk per 100,000 that they might face. So the handbooks we have that are going to be available to you on Blackboard, in each one of them, there are detailed instructions on how to use them. So I'm going to go through the simple approach. I'm using the instruction set for the adult radiography, but the other instruction sets are analogous, comparable. So the first thing you do is select the exam you're interested in. We want to know what the dose was from a given study. I just showed you AP pelvis. I showed you the table for that. Now, in clinical practice, there's often more than one projection. So, for example, that AP pelvis might be matched with a lateral pelvis, or often when you do chest x-rays, you do PA chest x-rays and lateral chest x-rays as a set. And so you may have multiple calculations to do to get the dose to a patient from a particular episode in the clinic. So the next thing we need to have is what the entrance skin exposure is and what the half-A layer is for this particular exam. So at the last physics survey, they measured the output from the x-ray tube, take their measurements, you scale them for the distance to the source to the entrance point of the skin. You get the HVL that they measured, and we're going to use those on our table. The other thing you can do is use reference data for what's typical for a clinical x-ray machine, and that information is provided in the handbook. It tells you where you can go and get that reference data. It's better to use measured data because each machine is slightly different, but if you don't have that available and you need to make an assessment, you can do it that way. The next thing you do is go get the coefficient that I just showed you for the particular study, for the particular HVL. You get your coefficient. This is for, as I said, an AP pelvis, a female AP pelvis. We want to get the dose to the, or the cancer detriment index. We knowing our HVL, we get the coefficient, and we multiply it by what the entrance skin exposure is for the mass that was used, milliamps times seconds, that was used in the study. The instructions have additional caveats and adjustments that relate to bone marrow, because the area that's exposed in a bone marrow is much smaller than the area of the field of view. So testes and ovaries, that in the past have been it's been common to use gonadal shielding. That's no longer recommended, and so those recommendations relate to the shielding might be possible if gonadal shielding was used. But that's how you go about it. It's a straightforward calculation, just like the nuclear medicine calculations were. We get a dose coefficient, we find out what the entrance exposure was, or we look it up from our last survey, and we calculate what the patient would be. Okay. Let's see. Next, let's move on to CT dosimetry. We spent a good bit of time before talking about the CTDI. Had some homework dealing with CTDI, which is the computed tomography dose index. As I said back then, it's an index of patient doses. It's not the actual dose to a patient, based on either 16 centimeter for the head or 32 centimeter for the body. Hunks of plastic with pencil ionization chambers inserted into them. A better way of assessing patient dose is what's called the size-specific dose estimate. The size-specific dose estimate is based on, guess what? The individual patient size. It turns out the best parameter to use for assessing doses to a patient is something called the effective diameter. That's the square root of the front to back AP distance times the lateral side to side distance. Multiply those together, take the square root. That's the effective diameter of the patient. And in the AAPM report 204, they derive that, why that's important. Notice what's interesting here is as size gets smaller, the dose coefficient gets higher. So we're going to multiply our CTDI by these dose coefficients, and they get bigger as the patient gets smaller. And why is that? Because the deep tissues are getting more dose. They're not being attenuated by the exterior tissues for a smaller patient. As I note here, AAPM, American Association of Physicists in Medicine, report number 204, describes this methodology, the size-specific dose estimate. I'm going to put it in banner for you, and in that report, you'll find tables that show, as a function of effective diameter, what those conversion factors are, which are the same numbers that are on this curve. So as you get to at about 34 centimeters, it's close to 1. Dose that's measured in the central axis is the same as the dose that's being delivered. As you get smaller, it almost triples down to 8 centimeters. And there are other parameters that are available that can be used. Just using the AP front to back thickness is possible. Just using the lateral thickness is possible, or using the sum of the front to back and side to side thicknesses is also possible. This shows you, this is showing the correlation between the sum of the dimensions and the effective diameter, which is the product of the dimensions to the square root of the product of the dimensions. So it's a pretty good correlation, and so these numbers can be used either way. But on a theoretical basis, the effective diameter is the best parameter to use. And why would we have these just for AP or just for lateral? Well, sometimes it's going to be difficult to know both dimensions in a patient before they're scanned. After the patient's been scanned, you can just look on the scan and see what the dose is. But if you want to estimate the dose prospectively, you may not have all the data available. So you can use one data point or the other data point and estimate what the dose is going to be. Okay. But and I think on the next slide is when we're going to talk about, so you just simply multiply the dose that's measured on the central axis when you did the CTDI measurement, get that number, and multiply it by these conversion factors for, well, it's actually by the CTDI volume, I think. Yeah, you use CTDI volume. You remember that's, anyway, you take that, multiply it by these conversion factors, and you get the actual dose. So it's inflated for smaller patients. Now we're going to talk a little bit about fetal dosimetry in case a patient is pregnant or discovers they're pregnant after exposure. One bit of data that's available, or a report or guidance that's available, is an ANSI standard, ANSI N13.54. It's fetal radiation dose into a long list of how to do radiation dose calculations in a medical environment. I talked about ICRP 84. I talked about the NCRP standard that's applicable. That those documents also have guidance on how to handle radiation dose calculations in applications. ANSI N13.54 has sections on radiation oncology, how to assess dose in that situation, in nuclear medicine, and in diagnostic radiology. And that's broken down into fluoroscopy and computed tomography. So that's what we're going to use as our outline. I have a graph here to reiterate what we said before. The effect of radiation depends on the timing of the exposure. And so this is for, in mice, for a given exposure, the relative contribution for when the exposure occurred, and the relative contribution for the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the exposure occurred is the time of exposure. And the relative contribution for when the expos in the mouse and the equivalent human stage of development, and what the outcome was. Prenatal death was the most prominent outcome in the very earliest days in the pre-implantation stage, during the stage of organogenesis, um, uh, genital anomalies, or death near birth were the most common outcomes, and they're very time dependent. They seem to fall off after the organs have been formed. And so that's something I mentioned last time. I just wanted to reiterate that now. Let's go into radiation oncology. So when a patient is undergoing radiation therapy, either with external beam therapy or with brachytherapy, uh, an important part of the treatment planning process revolves around dose assessment. And so the medical physicist, dosimetrist, and physician who are involved in the treatment planning process are in the best position to assess radiation dose to an individual patient. The fetal dose is strongly dependent on distance from the treatment volume. It's not entirely necessary in many instances when it's wise to continue with life-saving treatment during pregnancy if the treatment site is far enough away from the, the fetus. Treatment in the pelvis, in the gynecologic treatment, is usually not performed during pregnancy. Um, and treatments may be modified by adding lead shielding, typically at least 5 half value layers, to reduce, to ensure a very low dose to the fetus during treatment. The service performs dose assessments. It's important to remember to include doses for diagnostic procedures or for simulation. So simulation is before they start, in order to develop these treatment plans, they have to perform imaging that simulates the actual treatment. It's done with a CT or done with fluoroscopy. But the point is there are imaging procedures that are done that also contribute dose, and those should be considered as well when dose. Okay, let's move on to diagnostic radiology. There's an ANSI standard that we talked about a moment ago. They provide tables that are very similar to the FDA handbook tables. There are a couple of them here. So these tables, table 4 shown right here, this is for a table 4-2 is for an AP pelvis radiograph, similar to what we said before. This gives us the patient dose, milligray, per unit entrance skin exposure, per Röntgen of entrance skin exposure. It's the dose coefficients are again based on the beam quality, HVL in millimeters of aluminum, and they're different for different stages. And that goes back to the differences in geometry, differences in size and location. And so you can see that there are different dose coefficients depending on the beam quality and exposure. Multiply that by the times the entrance skin exposure, and we get our answer. I did want to point out that the projection is very important. So this is an AP projection. That's anterior to posterior, front to back. This is a PA of the same kind of image, from the back to the front. And you can see that the dose coefficients are much higher. The dose to the fetus is much higher for one projection than for the other. So at 4 millimeters of aluminum and 3 months, it's for the AP front to back, 3.17 times the entrance skin exposure. The same thing, PA, is less than 1 per entrance skin exposure. So it's important to pay attention to the details, I guess, is the point. And now, this table on the right also taken from the ANSI standard, shows typical values that have been published for the different studies using generalized technique factors, generalized HVLs, and these are going to be in the right ballpark, given the entrance skin exposure that one might expect for each of these studies. So you can see what the doses typically are at different stages of development. So we're talking about something for an AP pelvis, 1.5 milligray, 144 millirads at conception. A little bit different as time goes on along, but something like a spine, thoracic spine, so in the upper chest area, much lower exposures, and so it's 0.8 microgray for a 3-month-old. Several microgray would be the exposure, so a much lower exposure. But these are typical numbers that could be used to get a sense of what the exposure would be to decide whether it's worthwhile to go forward. Fluoroscopy is more difficult. Each study is different. It takes a different amount of time. Positions are in patient is in a different position. It's done dynamically. It's not just set up and shot like a radiograph is. So there's usually not sufficient information to get an extremely precise dose, but we can use typical published values to characterize generally what the patient's dose would be. And for different fluoroscopy studies that are done commonly, you can see what the doses are. They're on the order of 1 to tens of milligray, so hundreds, tens to hundreds of millirads exposure as a result of these typical kinds of studies that are performed. So knowing what an individual patient experienced, that is what studies they underwent, you can get a sense of what their exposures could be. As you recall, there is a handbook, FDA handbook, related to fluoroscopic studies. And so if you can get the clinical information, how much time the patient was in each position, what kind of exposures were done, you can do a more precise calculation using the dose coefficients in that handbook. Okay, computed tomography in the case of pregnancy. Oh yeah, that I should mention. These are fetal doses. So what you would look for, typically, if it's an early pregnancy, when you do the handbook, you would use the uterus dose in those tables, the non-gravid uterus taken as a surrogate for the dose to the fetus. Okay, computed tomography. When we're doing CT studies and we need to evaluate dose, a fetal dose as a result of a CT study, then it's going to be a little more complicated. And so I'm going to try to describe for you how those doses are assessed. So we said before, the CT dose assessment is based on when we did the size-specific dose, we use the central CTDI pencil chamber reading, and then so that's typically what's used for the fetus if it's in the beam. Plus, we need to add in contributions from the scans on the sides of the patient, scatter that's going from the slices before and after the fetus that are scattering into the patient. Okay, the formula for doing that is given in the ANSI standard that you'll have, and it's parameterized by a factor called the integral normalized fetal dose ratio. Okay. And I'm going to show you how to use this. So the dose is our axial CTDI times what's called the INDFR-E, effective INDFR, FDR, not DFR, INFDR. So, I've got to fix all these slides before I give it to you. So you'll have a clean set in the contents on Blackboard. So the INFDR effective dose. Now, what is the effective INFDR? It accounts for, as I said, all the scatter due to slices that are next to or nearby the fetus. And here's the formula. And here are the INFDR parameters. So those are the values of them. And here's the formula. And I'm going to show you on the next slide what INFDR0 is the INFDR or the slice where the fetus is, the center of the fetus is in the slice. If the fetus is in the scan, then it would be the INFDR for that is 0.255. If it's in the scan, it's at 0 centimeters. It's in the scan. It's not offset in the scan. If it's not in the scan, the INFDR 0 is 0. There is no dose due to the ball scatter. Now, this complicated formula, INFDR is the scan that goes through the fetus. The INFDR, the other portions, what we look at is for above and below the patient, inferior and superior to the patient, we look at what's the maximum distance to the scan and what's the minimum distance to the scan. So if the fetus is in the beam, so this block represents all of the slices that are in the scan. From 1 centimeter, so we take INFDR 1 is the minimum offset, 1 centimeter is the minimum offset. We go out to the maximum distance, let's say it's 10 centimeters. We would use the INFDR for 10 centimeters. We would take that larger one, the 10 centimeter one, minus the 1 centimeter one, and we divide that by the pitch. Pitch, remember, is the travel distance divided by the slice thickness. So this is essentially the slice thickness divided by the travel distance, the distance between slices. Okay, so we take that thickness divided by distance, take our two INFDRs, subtract them. We do that for what's above, inferior, or superior to the fetus. What's inferior to the fetus, get that pair too. And we put them into this equation. We subtract them. We multiply by the thickness divided by the slice spacing. Add in the fraction that's the factor that's due to, if it's in the beam, we add that in. If not, we don't. This one shows a fetus in the beam, so that's the minimum and maximum below, minimum, max above. If the fetus is not in the beam, one of these goes away. There is no slice inferior to this, only superior, only above the patient. So the maximum distance, let's say it's 40 centimeters, 0.841. The minimum distance, let's say it's 10 centimeters, 0.453. I subtract those two. I divide by the pitch. All of that, and the INFDR in this case is 0. It's outside of the beam. All that gets multiplied by the CTDI axial, and that gives me what the dose is to the fetus. So this just accounts this complicated part here where we're taking maximum distance, minimum distance. That accounts for all the scatter from distant dose. What the INFDR 0 tells me that for whatever I measure on the dose to the on the axis with my ion chamber, the dose of the fetus is 0.255 times that. So that's all of this is explained with examples in the ANSI standard. So I'd like you to go over that. Here are some typical doses that have been published, the ANSI standard, for a CT scan of the head. The uterine dose is less than 5 microgray, very low dose. It's a great distance away. so that that subtraction is leading to almost zero. For chest, it's 60 microgray, so about 6 millirads to the fetus. For an abdomen, so a little bit higher, it's lower, closer, it's maybe 8 milligray, 800 millirads. CT of the pelvis, 25 milligray, 2.5 rads. And for lumbar spine, 2.4 milligray, so about a factor of 10 less than the pelvis. Okay? Now, let's go through a little bit and talk about occupational exposure in radiology, radiography, and that sort of thing. We talked about occupational exposure for nuclear medicine workers. Now we're going to round that out by talking about exposure in radiography. Now, again, the exposure for the workers is often non-uniform, not because of inverse square necessarily, because workers are typically far enough away that the point source isn't diverging that much. Protective aprons that gives rise to the non-uniformity of radiology. And also the beam is divergent because we're talking about scatter, which is a large source, not a point source. In any event, now when 10 CFR 20 was first amended to its the current standards, originally all external exposures had to be treated as uniform, and they had to be the maximum measured value anywhere on the body. They realized because of this non-uniformity, that doesn't make a lot of sense. So they amended the rules, I think, in 2007 to allow something called the external effective dose equivalent. Effective dose equivalent external, EDEX. You might wonder, why does the NRC care about exposures to X-ray sources? X-rays are under the jurisdiction of the states. C is responsible for radioactive materials. And the answer is many workers work with both. And so if any portion of your exposure occurs because of exposure to radioactive material, the NRC is concerned about all your occupational exposure. And so workers and institutions can get in trouble with that oversight. Months ago, maybe 4 or 5 months ago, I read a notice from the NRC about a hospital in the Midwest where a radiologist was uncooperative about wearing their dosimeter. The hospital and RSO didn't take action to require the radiologist to behave, to wear his film badge. And both the radiologist and the hospital were fined as a consequence. Radiologist was involved or brought into the NRC because in addition to doing work with X-rays, he also placed microspheres, radioactive microspheres, into source spheres are called, into patients. And so he worked with radioactive material as a portion of his work. And so that was see that this can become an issue for institutions, and why RSOs and health physicists need to be alert. Okay, so in order to do this external dose equivalent external, this EDEX, effective dose equivalent external, the way that's done in the NRC world is we take all those tissue weighting factors that we had from the ICRP, we reallocate them. Some of those tissues, some of the red bone marrow, some of the different organs are in the head and neck. And so we create a compartment, add up all the tissue weighting factors that are in the head and neck. That probably includes the thyroid. And those are part of the head and neck compartment. Take the thorax above the diaphragm, take all the tissues, that portion of the bone marrow, that portion of the bone surfaces, all those the things that all the tissues that are in that region. The weighting factors for those tissues are lumped together and create a compartment factor in lieu of the tissue factor. Same thing for right upper arm, thighs, etc. And so we have these compartment factors now. And so you can see this is effective because we can look at what's underneath the apron. Is the neck is outside of the lead apron, the thorax is under the lead apron, the abdomen is under the lead apron, the thighs are under the lead apron, but the left and right arm are outside of the apron. So we can assign what dose outside of the apron and what dose, how much of the body is outside of the apron, and the dose for outside of the apron should be applied to that. How much is under the apron, and the dose measured under the apron should be applied to that. And that's just what we do. So when wearing a lead apron, if there's only one dosimeter worn, it should be worn at the neck level, and then the effective dose equivalent from external for that is going to be 0.3 times the unshielded dosimeter. That's what DU stands for. Now, this particular formula was developed in the state suggested regulations by the Conference of Radiation Control Program Directors, and so that's one of the approved methods that can be used. It's very common, though, to wear two dosimeters. Now, reducing by a factor of 0.3 may not be enough in many circumstances, may not be enough to keep people under the limit. So you may be overestimating what the actual external effective dose equivalent is. So it's common to use two dosimeters, one worn under the apron in a shielded position at the waist, and another worn at neck level outside of the apron in an unshielded position. There are two formulas that have been approved under those circumstances. One is developed in NCRP Report 122. You take 1.5 times the shielded dosimeter, and you take 0.04 times the unshielded neck dosimeter, add those together, and that gives you an estimate of the EDX. Now, if you have low shielding, that may overestimate the EDX, so it's not necessarily the best choice. Another possibility that's developed in ANSI 13.4 and 13.41 is another approach that takes 0.89 of the shielded dosimeter, so all the compartments that are shielded, plus 0.11 of the unshielded dosimeter, and add those together to get your effective dose equivalent. And so that may be the one that's most beneficial. Then whatever this effective dose equivalent external we come up with, that's going to be subject to the regulatory limits. The unshielded dosimeter on the neck is going to be a surrogate for the eye. It has to be less than 15 rem. The sum has to be less than 5,000 millirem, or 5 rem per year. The 15 rem is per year, etc. And also, the extremities need to be less than 50 rem per year, etc. Okay, and that's what we have. So that covers everything that I wanted to do today. Let's see. Let me turn off the slide. Can't seem to get over there. There we go. So, as I said, I would like to get some sample problems for you, but we need to get ready for a test. I don't know how much time we're going to have. Maybe I'll just work out. Well, I'll give you some to work on. Hopefully over this weekend I'll be able to develop them. And then we need to decide on a time for review. And then we can begin, we can schedule the exam. My usual practice is to give you a week from whenever I open it up until the due date. At sometime during that week, you'll need to take the exam. A limited amount of time once you start it, and then we'll go there. So please send me your feedback by email or however, and I'll be happy to work with you as we move on the rest of the semester.